Hello, everyone, and welcome. I am Sue McCann, Services Manager at the Foundation. Thank you for joining our Answers from the Experts Q&A program. We are very excited to have you here. Before I introduce our wonderful experts, I'd like to go over some housekeeping details. We are here for the Q&A, and you have joined us to be able to ask your questions. To do this, there is a tool in Zoom where you can enter your questions. So be sure to use this tool rather than the chat feature to enter your questions throughout the program. We are recording this, and it will be available in a few days on the Foundation's YouTube channel. We would also like to thank our individual donors and our funding partners for making programs like this possible. We cannot do it without their support. This is how we exist, and this is how we're able to produce patient education forums, webinars, publications, and other educational materials. So thank you for your donations. Finally, upon conclusion of the webinar, there will be a survey that pops up on your screen as you exit. We would appreciate you taking the time to complete this survey. Now, it is my pleasure to share some information on our speakers for today. Today we have Dr. Jina Chung and Dr. Tarsheen Sethi. Dr. Chung serves as an assistant professor of clinical dermatology at the Perelman School of Medicine at the University of Pittsburgh, Pennsylvania, in Philadelphia, and is a board-certified dermatologist and dermatopathologist specializing in cutaneous lymphomas. Dr. Chung sees patients in the clinic and also analyzes skin biopsy specimens under the microscope. She's a member of the American Academy of Dermatology, the American Society of Dermatopathology, and the United States Cutaneous Lymphoma Consortium. We also have Dr. Tarsheen Sethi, who is a board-certified hematologist, oncologist who serves as assistant professor of medicine at Yale University School of Medicine, the Yale Cancer Center, and the Smilow Cancer Hospital. She specializes in treating patients with Hodgkin and non-Hodgkin lymphoma. Dr. Sethi also holds a Master of Science in Clinical Investigations and is an active researcher. Some of her research addresses a rare category of lymphoma that focuses on treatments using new drugs and multi-drug combinations, helps to improve quality of life, the speed of patient referrals, and the use of different drugs. She is helping to build a database of information on chemotherapy treatments that is shared freely throughout the world. With those introductions, let's go ahead and get started and welcome Dr. Chung and Dr. Sethi. Thank you so much for joining, Dr. Chung.
Thank you, Sue. It's good to be here.
And thank you, Dr. Sethi, also for joining us.
Thank you so much, Sue. It's a pleasure.
Great, thank you. Before we go to our first question, as a reminder, Drs. Chung and Sethi are here offering their opinions and answers to your questions based upon their experience and knowledge in the specialty of cutaneous lymphoma and through experiences with their own patients. These are not second opinions, and any specific questions that you have should always be asked of your own medical providers. With that, we're ready for our first question. Will my CTCL ever go into remission, although there is no cure?
Yeah, this is a really good question and one that a lot of patients ask. And it depends on the stage, and it can go into remission. Sometimes when you have really early stage disease, sometimes we don't always shoot for 100% remission, because a lot of early stage patients have really good prognosis, even if they have a little bit of leftover disease. So we try to manage the risk against the benefits and try to find the treatment that preserves the patient's quality of life in the best way.
Thank you, Dr. Chung. And absolutely, I agree with that as well, that, it's very, CTCL is one of the diseases where quality of life is of utmost importance because it is ultimately a chronic disease, especially in early stages. And so,
Okay, thank you both. Next question, is a cherry angioma a side effect of phototherapy? How do you prevent it from growing bigger and eliminate it?
So cherry angiomas are benign kind of growths of blood vessels. This is not a side effect of phototherapy. This is actually a very common growth that over 50% of the population has. So it's not something that we can necessarily prevent development of, and it's not a harmful thing. If you wanted to treat them, it would be mainly for cosmetic reasons. And sometimes you can do lasers, like vascular lasers, that target the blood vessels for treatment, but it would be a cosmetic treatment.
Thank you. Next question, does a patient with Sezary on ECP once a month for 2 days in succession always need additional drugs? In general, how long can they maintain on ECP alone?
So so for photopheresis, it is a pretty effective treatment for example, for Sezary syndrome and erythroderma. And we really try to maximize every line of treatment that we use for this condition. And so our preference is generally to use combination therapy, for example, in combination with interferon, as well as the other options include low-dose methotrexate. And ultimately, is we want to try to get the best response. We sometimes do use photopheresis alone for more a maintenance approach in patients who've already achieved a good response. In general, the response rate for photopheresis is in the 50 to 60% range, and a little bit better with those combinations rather than ECP alone.
Thank you. Two-part question here. I have patches on the inside of my thighs. Can I use natural sunlight to treat them? Also, how useful are the home UVB handheld lights for treating localized areas? And can you recommend a good brand that's been tested for CTCL? What should I be looking for in a home treatment unit?
It's a good question. Sometimes we do recommend natural sunlight for about 15 minutes a day for patients who are unable to do office phototherapy or are unable to get a home unit. I will say that the inside of the thighs is sometimes a challenging area to get natural sunlight because it's not an area that's normally exposed when you're like walking outside. And you just have to be careful not to get burnt. Handheld narrowband UVBs are sometimes prescribed. I will recommend generally a prescription FDA-approved device over like over-the-counter devices that sell on Amazon or eBay, because those are not really there's not really validated tools. So if patients are going to do home phototherapy, I generally recommend an FDA-approved device, such as their brands like National Biologic, Davalin. They're pretty comparable. So it's whichever one your doctor prefers. And I think that home phototherapy units are really nice if you can get it covered by insurance or if you are able to afford the payment. They're just pricey upfront, but it is nice to have at home. That way it can save you a lot of time traveling to in-office phototherapy. And the FDA-approved devices are quite good and even comparable to office phototherapy.
Thank you. Another two-parter. What are the most successful treatments for CTCL with Sezary syndrome? Are there any new clinical trials that could be effective for Sezary syndrome? Is there any evidence that herbal products in combination with monoclonal antibodies or chemotherapy help or hinder treatment? Dr. Sethi, do you want to take that one?
Yes, thank you. So again, Sezary syndrome does remain a very challenging disease. It's advanced stage CTCL. And so as we alluded to before, photopheresis is often in combination is used as a first-line treatment for many of our patients with erythroderma and Sezary syndrome. And Thankfully, in recent times, there have been more treatments now that work well, especially in the blood compartment. For example, mogamulizumab. In terms of new trials, one of the recent drugs that is not yet approved for use, but it has shown really good promise is lacutamab. It's an antibody drug that does show preferential activity in Sezary syndrome. So, that we are getting more and more treatment options. Some of the traditional therapies do also work in Sezary to some extent. What I mean, the other single agent treatments like romidepsin and pruritis, but it's not as a robust of a response as we see with mogamulizumab, for example. And in terms of the herbal therapies, again, what we suggest is that, there's not much regulation to supplements. So we really worry about drug interactions when patients are on chemotherapies or immunotherapies. And so what I would suggest is that you always discuss it with your physician and basically, and then otherwise, in general, just try to avoid over-the-counter supplements without prior approval.
Okay, thank you, Dr. Sethi. What experiences have you had prescribing Campath or Alemtuzumab? And do you have any tips for how to be successful with this treatment?
Yes, so Campath, it's an anti-CD52 antibody, and it has been around for a long time. And we use it for a number of different T-cell lymphomas. But in CTCL mycosis fungoides, it's not really one of our main lines of treatment. We tend to use it in patients who have not responded, basically have gone through all the other options that we have, both because it's not as effective and also because of potential side effects. And we do tend to use it a little bit more commonly in conditions like TPLL, which is another form of T-cell leukemia that can sometimes involve the skin. So in terms of the main precautions with alemtuzumab is the risk of infections, especially CMVR reactivation and PJP pneumonias. And so it's very important to stick to all the preventative antibiotics that are given, and we also monitor, with checking for CMV activation for patients on treatment. Another important thing to remember with alemtuzumab is that it can, for patients who are actually, and this is going to be a very minority of patients, but especially patients who've been through multiple lines of treatment, some of them may be considered for allogeneic stem cells transplant. And we don't want to give Campath too close to an allogeneic stem cell transplant because the T cell depletion that it causes can result in engraftment issues as well as increased risks of infections.
Thank you, Dr. Sethi. It's a complex treatment and management with alemtuzumab. Okay, next question. This person has had MF, mycosis fungoides, for 44 years. Did UVA 15 treatments and UVB since with bi-monthly treatments. Body is loaded with brown spots and severely dry and has had several skin cancers. Any suggestions what I can try next? He's 85, she's 85 years old. Dr. Chung.
That's a good question. Well, assuming that you have question asker has early stage disease, which it sounds like because their disease have been managed on phototherapy primarily. UVA is associated with increased risk of skin cancers, but UVB not necessarily so. There's no data so far to suggest that narrowband UVB increases risk of skin cancers. And I think that it's hard to suggest treatment without knowing the patient's full kind of medical history and other diseases that they may have. But if they're 85 years old and have skin limited early stage disease, then I think that at that point, I really try to weigh the risks of treatment against the benefits and try to pick treatments that would preserve quality of life while also not causing harm. Because I would not necessarily recommend kind of a aggressive systemic treatment for someone who is 85 years old and has early stage disease that will not have an impact on their life. So I think that it kind of depends on your stage and kind of your quality of life and how bothered you are by your treatment. But sometimes, I will add on treatments like low dose methotrexate that can sometimes be a helpful addition to your light therapy. Sometimes I might add on something like acitretin that can also be a little bit helpful while minimizing it can also have some chemopreventative properties, like it can reduce the number of squamous cell carcinomas that you may get in patients who have had long history of PUVA treatment. So these are some of the lower risk systemic agents I may consider, but it would really depend on your medical history. So I recommend discussing with your doctor.
Great. All good points. Thanks. For stage 1 mycosis fungoides with patches and a few plaques, when is phototherapy the best course and when is methotrexate better? The goal is remission.
Yeah, so this is kind of similar to what I was saying earlier. So in stage 1 disease, it is not always possible to get 100% remission. And we always have to weigh all the benefits of the treatments against the risks. I think that phototherapy is a good option depending on your disease state. If you have like thin patches, I think phototherapy is very good. It's a very effective skin-directed therapy. Sometimes I will add on methotrexate in addition to phototherapy because I do think that it makes your skin a little bit more photosensitive, so it increases the efficacy of the phototherapy. So I think it works well as a combination treatment. Methotrexate monotherapy can also sometimes be considered, but I think if you have early stage disease, and then skin-directed therapy tends to be the kind of the mainstay of treatment, and in my opinion, can be more effective than methotrexate monotherapy. Combination methotrexate and phototherapy is also good.
Okay, thank you. I was diagnosed in 1988 at age 25 with stage 2B Hodgkin's lymphoma. In May 2025, at age 62, I was diagnosed stage 1B with CTCL mycosis fungoides. Is there any concern with my prior history with Hodgkin's lymphoma? Thanks. Dr. Sethi, want to take that one?
Yes, sure. So yeah, Hodgkin lymphoma beyond the 5-year mark is considered, classical Hodgkin lymphoma is considered cured. We do have, late relapses are really very, very rare. Again, this is a different disease that you've now developed, which is mycosis fungoides. But in general, classical Hodgkin lymphoma is considered cured at around the 5-year mark. So I would not expect any kind of contribution to that prior history. The only other thing is I'm not sure at that time in 1988 what your stage of was and how much radiation you got. And again, CTCL is not one of those skin cancers that is associated really with radiation exposure. So I can't really think of much of an association between the two conditions.
Okay, thank you. Okay, a two-part question here. I have hyperpigmented mycosis fungoides and I have coverage from my face, about 10 to 15 spots, down to my feet. I was diagnosed last October. I saw my first spot last June or July, stage 1B. I have CD positive 8, 3, 4, and 7 markers. No one can seem to tell me anything at my current treatment center. Why is hyperpigmented so rare and what can be done to help me?
So mycosis fungoides can be hyper or hypopigmented. I think mycosis fungoides itself is a rare disease. But hyperpigmented mycosis fungoides is not a particularly rare variant of MF. They can be hyper or hypopigmented. And I think that if you have early stage disease, then I think that the best treatments would be skin-directed therapies. So that includes topical steroids. Sometimes we add on things like topical nitrogen mustard. Sometimes we also add on phototherapy. Sometimes, depending on the level of disease involvement and whether you have thick plaques, we might add on systemic agents such as methotrexate, interferon, bexarotene. So it really depends on your disease stage. And I think that if you feel like you're not getting answers at your current treatment center, then you can certainly seek out kind of a referral center that specializes in cutaneous T-cell lymphoma. And I think you can find such information for treatment centers on the CLF Foundation website.
Right, good point. Next question. On methotrexate, 2.5 milligram once weekly for 6 weeks and twice weekly light treatment. I'm having increased frequency of headaches that are relieved with Tylenol, pruritis or itching, and cracking of skin persists, and using triamcinolone on wet skin for 2 weeks. Hard question. How long will it take for improvement? Who would like to take that?
I can take this one. So it takes a while for methotrexate to kick in. It usually takes an average of a minimum of 2 months for methotrexate to reach a dose where it will have clinical effect. That being said, I'm not entirely sure about the dose, if 2.5 milligrams is the dose that the patient is on, because it is on the lower dose end. Maybe it's like a starting dose and it will be increased. But 6 weeks is a little early on to see improvement from either methotrexate or phototherapy. Mycosis fungoides is hard because it's a disease that takes a long time to improve, more than other dermatologic conditions like psoriasis or eczema. So it's a disease where you have to be patient. Unfortunately, it will probably take a couple more months on methotrexate or phototherapy.
Thank you. Next one. With my recent May 2025 MF diagnosis, I feel more fatigued. Is this common, and when does it become a real concern? Thanks. Dr. Sethi, would you like to take that one?
Sure. So again, mycosis fungoides it is an indolent disease. So we don't really expect it to cause what we say a lot of constitutional symptoms like fatigue. So what I think it will be helpful to understand what else is going on that is causing fatigue. If the patient is awake because of pruritis and it's affecting their sleep, that might be a reason. Another reason is that I'm not sure what treatment has been started. Sometimes patients, when they're started on bexarotene, they can develop hypothyroidism, which is a low level of thyroid hormones in the body, and that can also present as fatigue. So I think it's helpful to understand what exactly is going on, and I do not expect mycosis fungoides by itself to cause fatigue unless we're talking about more advanced stage and large cell transformation.
Thank you. What is the best treatment plan for a 7-year-old female whose health is fair that will last?
So
Dr.
I
Chung?
think it's a difficult question because it's unclear what the child has. So I think that the treatment recommendation would depend on the diagnosis. So if you want to share in the Q&A part, feel free to share a bit more detail.
Okay, thank you. Two-part question. I have mycosis fungoides for 20 years. A year ago, I developed large cell transformation. I had good results from brentuximab, but developed peripheral neuropathy. I then switched to Keytruda, but it was not effective. My doctors are considering Gemzar for the next step. Do you have any suggestions for treatment? Thank you.
Yeah, large cell transformation is definitely, very challenging. It's, it's a sign that the disease has changed kind of course. The site of large cell transformation is very important to know, because skin only large cell transformation, can still be managed with single agent treatment, whereas large cell transformation that goes beyond the skin, involving the lymph nodes or other external sites, really oftentimes needs combination chemotherapy agents, similar to what we use for other types of T-cell lymphomas. Having said that, if my presumption is that if the patient's being treated with single agents, is that we're primarily talking about skin large cell transformation. Again, it's very hard to make treatment recommendations. It's a discussion that needs to happen with your physician. However, beyond brentuximab, single agent chemotherapeutic agents like gemcitabine and Doxil, that is liposomal doxorubicin, are definitely reasonable options. Romidepsin sometimes does work if it's skin only large cell transformation. But again, it's very important to understand the site and the extent of the large cell transformation. And if the disease is acting very aggressively, then it would be time to consider combination chemotherapy, which basically is regimens like CHOP.
Okay, thank you. What tests are done other than biopsies to diagnose cutaneous T-cell lymphoma? Maybe both of you
Good
can
question.
respond to this.
Yeah, I can start. So if you have a biopsy that looks like mycosis fungoides or cutaneous T-cell lymphoma, then typically we check some basic labs. We might also check up peripheral blood flow cytometry, which looks at your blood to see if there's any atypical white blood cells that look like Sezary cells. If you have tumor stage disease, then we might also check imaging like a PET CT or a CT to look at your lymph nodes to see if you have any potential lymph node disease. And if there's any suspicious findings on imaging, you may need a biopsy of your lymph nodes. So these are some of the tests that we might order. I think part of the thing that makes it hard is that if you are trying to diagnose mycosis fungoides, then patients often ask me, is there a blood test that will tell me whether I have MF or not? And unfortunately, that blood test does not exist. So a blood test like a flow can tell whether you have Sezary syndrome or not. But mycosis fungoides is a diagnosis that has to be made via a skin biopsy.
Yes, and I think I'm just gonna add that it's the initial diagnosis of mycosis fungoides can be very elusive, and so it's very important for patients, especially because sometimes patients who have been otherwise diagnosed as psoriasis or atopic dermatitis actually end up having mycosis fungoides. So it's very important when we have patients who are not responding to standard treatments for these other diseases, for for patients to be evaluated at specialty centers that have expertise in cutaneous lymphomas. And then because then not only can we help make that diagnosis, but it usually takes Dr. Chung is both a dermatopathologist and a dermatologist, but it takes expert pathologists, dermatologists, hematologists, and the radiation oncologists to make the multidisciplinary teams for this disease.
Yes, I agree, Dr. Sethi. And then I also want to mention that you can also sometimes do clonality testing where we sequence the T cell receptor gene. And sometimes we do the test in multiple different skin sites to see if there's identical T cell clone in multiple different sites of your skin. And sometimes that can also be a helpful clue to diagnosing cutaneous T cell lymphoma.
Great. Thanks, both of you. A two-part question. At what point does UVB light treatment danger to cause melanoma outweigh the benefits for CTCL MF stage 1A? In 30 years, I have had 3 sessions of 3 times a week, only gradually increasing up to 2 minutes a session. This has worked to clear skin completely, and now it is back and could use another. Next part, let's see. The second part was just about, are there any new creams within the last 5 years that might be helpful? So she's tried a variety of creams and they didn't work well with UVB light.
Okay. So Narrowband UVB, there is no evidence so far that suggests that it actually increases your skin cancer risk. That being said, that would be a hard study to do because you would have to follow those patients over a very long period of time. It also, the risks of skin cancer from narrowband UVB, if it's a purely hypothetical risk, no proven risk. But even if that were to exist, it would also depend on a lot of other factors, like your underlying skin type, your other kind of sun exposure history, and things like that. So I think that it really depends on whether your doctor kind of feels that it is safe to continue. Because there are patients who have history of multiple melanomas that I probably wouldn't feel safe continuing phototherapy for a lifetime. But then there are also other patients who have had no skin cancers who I would feel perfectly comfortable continuing phototherapy for a long period of time just based on their skin type and inherent skin cancer risk. Regarding the regarding the other like lotions, creams, so unfortunately, no new FDA-approved treatments within the last 5 years, although there are several that are currently under investigation. We have one phase 2 clinical trial here at Penn that is currently investigating a new topical treatment called hypericin ointment combined with visible light. But I think there are other treatments that you can try. Topical steroids are also good. Topical nitrogen mustard. There's also like topical retinoids, such as topical bexarotene, that you can try. But those are kind of older than the past 5 years.
So I have used clobetasol gel for the clomethaphene gel, but my doctor has put me on hold for the time being as I am stage 1A and he wants to see how things shake out.
Okay, I think that's very reasonable. As stage 1A disease is an indolent chronic disease. And I don't necessarily think that you need to kind of throw all treatments all at the same time. And I think that if you want to try kind of even sometimes when they have limited disease, we do like a watchful waiting observation as well. So I think that topical treatments like clobetasol and methcrothamine gel are both very reasonable treatments.
What tests should be done to check your stage? It's a little different from our other testing question in the fact that it's asking about different stages and the testing that might be needed. Dr. Sethi, you want to take this one?
Sure. So again, as we discussed before, in the diagnosis question, for skin-only disease that is mostly patches or plaques, oftentimes, so almost in every patient, we will be checking their blood to look for any Sezary cells, which includes both using a flow cytometry as well as clonality studies that can be looking at a PCR, T cell rearrangement, or sometimes we have special flow cytometries that can look for clonal T cells in the blood as well. In terms of, in more extensive skin involvement, at that point, you really do want to undertake a PET scan. Most of us do prefer a whole body PET scan over doing CT scans because it will, does tend to kind of be more sensitive to the extent of disease. So again, in terms of the staging, it is a TNMB classification. So we're looking for skin involvement, nodal involvement, extranodal visceral involvement, as well as blood involvement to accurately stage the disease.
Okay, so this is a follow-up question to the 7-year-old, and the person is actually 70 years old, so that was a typo. Stage 1B. So what would be the best treatment considering those factors for a 70-year-old?
Well, I think that kind of what I've discussed before, treatment of early stage disease, the best treatments are skin-directed therapy. So that would include topical steroids, methocrethamine gel. You could try phototherapy. And then, if recalcitrant to those treatments, you could consider adding on a systemic agent such as methotrexate or bexarotene. But again, the benefits would have to outweigh the risks in an older patient. And it would depend on the patient's other health conditions as well. So please consult with your physician.
Very good point. Thank you. I have T-cell lymphoma. Is it possible that I can get into a remission with longer treatment? Part 1. So second piece of this is the patient has stage 2B and is being treated for 21 years with phototherapy and spot radiation treatment and bexarotene 600 milligrams a day.
The question was a little bit confusing, but I think my understanding is that it seems like the patient has long-standing disease and is now progressing to more advanced stage disease. And again, as Dr. Chung mentioned, once you've been through multiple skin-directed treatments, it's time to kind of think about more systemic therapy options. He's on a pretty good dose of the bexarotene, and so if the patient is still having we've given it a reasonable chance. If the patient is still having significant disease involvement as well, or it's affecting their quality of life, then it would be time to consider other systemic therapy options. We have a number of different agents like romidepsin. Again, it's very important to know what if we are dealing with just skin involvement, it's whether we are dealing with skin, lymph node, or blood involvement, because the agents that we have tend to work better in one compartment versus the other. And it would be helpful to know if this is CD30 positive disease, because there are agents like brentuximab that can be options. But again, we need more information, but yes, there are plenty of other treatment options if that is the question.
Okay, thank you. This one is a little bit more straightforward, is how common is mycosis fungoides, CTCL, and what's the prevalence and incidence of it?
So mycosis fungoides is a pretty rare cutaneous T-cell lymphoma. So incidence is around 1 in 100,000. So I think it's estimated there's about like 30,000 patients with cutaneous T-cell lymphoma in the United States. But the numbers are increasing. So this is based on, I believe, data from like 10 years ago.
My next one is my son began treatment at the Mayo Clinic in 2024. Large plaques on neck, arm, and legs. He's on several prescription medications along with light treatments. So the original plaques have darkened, and the question is, when will they disappear completely, if ever?
It's sounds like they have early stage disease. It's a little bit unclear what the prescription medications that they are on, but with prescription treatments and phototherapy, you can get post-inflammatory hyperpigmentation, which is kind of like when the mycosis fungoides phase, it leaves like a dark footprint of where the rash was, and that dark patch can last for a long time. So it typically takes about 6 to 12 months for post-inflammatory hyperpigmentation to fade. And it is something that you have to be a little bit patient with. Sunscreen can help prevent further darkening of the post-inflammatory hyperpigmentation. So it is something that I generally recommend in my patients who have dark skin, who tend to develop more of this post-inflammatory hyperpigmentation.
Okay, there's more from that same patient. So new plaques have started to form and have started to fade away. How long will we have to take medication to prevent future attacks? And what are the treatments that have the most success?
Well, assuming that he has early stage disease, I think I kind of touched based upon the skin-directed therapies and other kind of systemic agents that you can try for early stage disease. And, I think that it's important to think about this as more of a chronic disease. So it is likely that he will have to stay on some treatment for a long time. Sometimes you can kind of taper off the systemic agents if you're doing well, and maintain on phototherapy alone. But it really kind of depends on his disease stage.
Okay, thank you. I have FMF, which means follicular mycosis fungoides. What are your thoughts on getting tattoos for someone who is stage 1A?
So follicular tropic mycosis fungoides tends to kind of go down the hair follicles. It is a subtype of MF. So getting tattoos does not really exacerbate or improve mycosis fungoides, so it has no impact on it. As a dermatologist, I do have to say that tattoos can cause other rashes. Sometimes patients can get allergic contact dermatitis from tattoos. Sometimes patients can also get kind of atypical mycobacterial infections from tattoos. So it is something that I do caution my patients that it's not a completely risk-free thing to do, but it will not impact your MF.
Okay, thank you. So this person is awaiting biopsy results. The dermatologist is confident they have lymphomatoid papulosis, but they're awaiting the biopsy results. There are over 30 lesions on the arms and legs that have started to subside slowly. Is that first outbreak typically the worst? Do subsequent outbreaks occur much like the preceding one? Also, has there been studies showing any dietary link to LYP? I have been told by many people to find a gluten and sugar-free diet that might be beneficial. Is there a link to gut health? I'm thankful for this foundation and for the information.
That's a good question. So if your biopsy does confirm lymphomatoid papulosis, this is a benign condition. So you will get kind of these papules that come and go, but by definition, they will go away on their own, but it can take time. And the main issue that is that sometimes it can kind of lead to scarring, which is the reason why patients might want to get treatment. So unfortunately, there's no like rhyme or reason to these outbreaks. So sometimes patients can get like a lot at once and then go many years without getting any. So it's not necessarily like the first one is the worst. So it doesn't really follow that timeline. So the subsequent outbreaks can potentially be just as bad as your first outbreak. There is no kind of proven dietary link to LYP. a lot of my patients also ask about like gluten and sugar. Unfortunately, we don't really have good evidence to suggest that either of those contribute to lymphomatous papulosis. And I generally just tell my patients to maintain a healthy, well-rounded diet. Same with gut health, really not a lot of good evidence to show a convincing link to gut health or microbiome or kind of probiotics, all those things. I tell my patients there's no proven link to show that those hurt or help MF. Let's see. I think that I answered most of those questions.
I think so. Thank you. Next question's a two-part again. And I think Dr. Sethi, this will be good for you. My father has been diagnosed with peripheral T-cell lymphoma, NOS, or not otherwise specified. Over the years, he has already received several treatments, such as romidepsin, total skin radiation, phototherapy, methotrexate, interferon, and most recently, due to an increase in Sezary cells, his treatment was switched to mogamulizumab. Can mogamulizumab cause peeling of the skin on the hands, or is this more likely a sign of disease progression? We live in Israel. How can we check the possibility of participating in clinical trials for new drugs? I'm trying to hold on to every bit of hope as I see my father suffering and the progression of his illness. Thank you so much. It's
Thank you for the question. It's that's why CTCL is such a hard disease, especially with Sezary syndrome, with the erythroderma, causes a lot of suffering. So we understand, and it's very hard to see your father go through something like this. And to specifically answer your question about mogamulizumab, so I'm not sure how long he has been on mogamulizumab. It does take several weeks to take effect. The peeling that is described of the hands can be, it can be a sign of the erythroderma still being active. However, having said that, mogamulizumab, if there is actually improvement followed by progression on mogamulizumab, then you have to think about whether this is mogamulizumab-associated skin rash versus true progression of disease, which requires a biopsy. Again, Sezary syndrome is one of the harder diseases to treat. Moga is definitely one of the more effective drugs we have. Having said that, there are newer drugs coming on the horizon. Like I mentioned, the lacutamab, but it's still not available even here in the US as standard of care. In terms of clinical trials, the best way to search for them is through the website, the clinicaltrials.gov, and that would be one of the more reliable sources. Again, since you're in Israel, I'm not entirely sure of any local platforms that you can use.
Okay, thank you. Now we have time for about 3 more questions. So this next one is a two-parter. My boyfriend has Sezary. He's on Moga for 12 months. His blood is completely clear because of the Moga, but he has a lot of red patches on his skin. Moga rash, possibly, question mark. It looks and feels different from the Sezary skin, and he loses a lot of hair. We are talking with our doctors about maybe trying to change from once every 2 weeks to once a month. What is the worldwide experience with lowering treatment with Moga? Would it help to reduce side effects, or is it a bad idea when blood is finally clear? Dr. Sethi, would you take that one?
Sure. So again, similar to the previous question, I think it's very important to first understand what exactly is going on. Is this truly mogamulizumab-associated rash, or is it progression of disease where mogamulizumab is no longer effective? And there is, in terms of if it is Moga rash, we don't really have any data to support that lowering the frequency is actually going to make it better. Even though there have been some studies, you know, looking at can MOGA still be effective if it is used less frequently. Then based on those, preclinical data, the studies, they have shown that less frequent dosing would still work. We sometimes use it off-label for some of our patients to maintain a response. However, in this particular case, it seems like the more important question is to understand what exactly is going on with this rash. Is it, if it's truly MOGA-related rash, it might need drug interruption and, management as depending upon what, how severe it is.
Okay,
I
thank
agree.
you, Dr. Sethi.
It sounds
Thanks,
like
Dr. Chung.
they need like a skin biopsy of this
Right.
rash to confirm that it's whether it's MAR or mycosis fungoides or CTCL.
Yes, Dr. Chung, can you just explain what MAR is?
Oh, I'm sorry. So MAR is mogamulizumab associated rash. You really need to do a skin biopsy to try to distinguish the MOGA rash from cutaneous T-cell lymphoma progression.
Okay, great. Thank you. Okay, our last two questions coming up. This next one is two parts again. 58-year-old CTCL mycosis fungoides CD30 positive with large cell transformation and some local lymph node involvement, currently on round 4 of 16 of brentuximab and responding well. My team views this treatment as a workup to a stem cell transplant, given age and fitness with a goal of curing the disease. Is this a reasonable approach, or are there other less aggressive recommendations? I have had extensive targeted radiation, topicals, phototherapy, and 4 years of immunotherapy since 2013 diagnosis. The term cure is new to me, so I greatly appreciate your expert insights.
Yeah. So it's a and a very important question with CTCL. We talk about it as being chronic disease, but really, once there is progression to a more advanced stage disease, involvement of lymph nodes or large cell transformation, definitely it is a sign that the patient will likely need multiple different lines of treatment to oftentimes to try to get to a reasonable response. And at this point, we definitely do think of allogenic stem cell transplant. Not every patient can, it's not an option for every patient. It depends upon how fit you are, your age, and a number of other things, because stem cell transplant, comes with, it's not an easy procedure. It comes with a very, very, significant, it can result in significant side effects. And so, but I do think in this particular case, the approach appears to be pretty reasonable. I don't know what the extent of large cell transformation is, if the lymph node is also showing large cell transformation, in which case usually patients will need more than just single agent brentuximab and, with the addition of other chemotherapy agents. But regardless, the goal for a young fit patient who has been through multiple lines of treatment and now has aggressive disease, the goal of bridging to transplant is very, very reasonable.
Thank you. It's a very complex issue. So, final question for the evening. What do you think, or do you think immunomodulators like vitamin D3 are good for CTCL? We know that low vitamin D contributes to many chronic illnesses, not just cancer. So would keeping vitamin D to a decent level be advisable, given that CTCL is an issue within the immune cells? Perhaps both of you could comment on that.
Yeah, it's a good question. There's not a strong evidence regarding the relationship between vitamin D and CTCL. That being said, so it's not really part of like a kind of the staging workup of cutaneous T-cell lymphoma. We don't routinely check it. It's not really indicated. That being said, vitamin D is good for your body for other reasons, such as bone health. So I think that if you have vitamin D deficiency, I think it's certainly reasonable to take a reasonable amount of supplementation. You do have to be careful not to overdose on vitamin D. So you should take whatever your doctor recommends. But right now, there's not a lot of strong data regarding the relationship between vitamin D and CTCL.
Dr. Sethi, anything to add to that?
No, I think like Dr. Chung said, I would just if you're vitamin D deficient, based on our standard criteria of less than 20 or even less than 30, it's reasonable to the supplementation is reasonable in the usual doses, but there is no real association that we know of with CTCL.
Okay, great. Well, thank you. I want to thank both of you for taking time out of your very busy schedules to share your time and expertise with us and with our community. It's very, very valuable to everybody. Before we close, I wanted to ask you, do you have any parting thoughts? Dr. Chung, would you like to comment?
No, I hope that you were able to gain something from this session for either yourself or your loved one. It's a very difficult disease. So I think that we're all working really hard to do the best we can to take care of patients with cutaneous lymphoma. So thank you for coming to the session.
Thank you. Dr. Sethi?
Thank you. So yeah, I first want to, I'm very appreciative of the Cutaneous Lymphoma Foundation, as I'm sure all the patients are, because this is, as Dr. Chung mentioned, such a hard disease and really can affect the quality of life. And so it's great that you all provide this platform where the experts and the patients can come together. I do think that one of the things that I want to mention is that if you have a diagnosis of CTCL, just make sure that you at least consult with a center that has multidisciplinary expertise in CTCL, because as you can see from the questions today, it's a very, very complex disease, and it's very important to consult with people who have experience with treating this disease.
Well, thank you both for those thoughtful comments and for helping us this evening. And thanks to everyone who attended tonight and for submitting your great questions. We hope it was helpful to you. My last ask is that you complete the survey, as it is very helpful in bringing information to us that helps us develop programs that are beneficial to you. So with that, have a good rest of your day, everybody, and goodbye for now.